So I want to say welcome to Journal Club. This is October, so it's only our second Journal Club of the year. We start in September, and October is our second. And I'm very thrilled to have Anna Handorf here. She is from the Harvard Contingency of Hospitals, and I'm really excited. And she can tell you about her role and how she got to her project about these what we call chalk talks of
Tiny
some
Talk.
what?
Tiny Talks.
Tiny talks for her, chalk talks, tiny talks, right? So many different worries. And here they are. Let's talk about it, right? Introducing the Tiny Talks curriculum. So, Anna, take it over and let us know who you are a little bit so we get the context. And I look forward. Any discussion can go in the chat. And of course, we always have questions for discussion. So please participate as we go along. We don't mean this to be a talking head to the group. So we
Absolutely.
pose some questions. Thank you.
Thank you so much. And thank you so much for inviting me. I appreciate the opportunity to talk to all of you. And I did put some questions in, so I hope that people feel able to be engaged, even if they are off camera. I will do my best to toggle back and forth to the chat. That can sometimes be challenging. So if I'm missing something in the chat, please someone can speak up so I don't miss it. Um, my name is Anna Handorf. Clinically, I'm a pediatric hospital medicine physician. I work primarily at a community hospital, Newton Wellesley, outside of Boston in Massachusetts. And I also have protected time at Mass General Hospital, also affiliated with Harvard Medical School, working on TinyTalks and in the Slavin Academy at MGH. And as of October 1st, I'm one of the new associate program directors for the pediatric residency program at Mass General, which is really exciting. And I come to you to talk about one of my main projects, the Tiny Talk curriculum. And this is something that I had the idea for when I was training as a resident at Mass General, and then had the opportunity to complete a fellowship in medical education and simulation at MGH. And this was my main fellowship project. And I then kind of leveraged that to help me continue working at Mass General developing Tiny Talks. We published an article in Academic Medicine earlier this year, which is what I'll be discussing. So my learning objectives for this talk. So by the end of this presentation, you should be able to describe the benefits of using Chalk Talks as a teaching modality, describe a standardized three-step strategy to create a Chalk Talk teaching script, what we call the hook, the frame, and the delivery, evaluate the implementation of the Tiny Talks curriculum at Mass General for Children, and hopefully be able to incorporate some short Chalk Talks of your own into your teaching practices.
I have a question for you. This seems perfect. Whatever you just did is perfect. There was a little bit issue with the slide.
Oh, okay. Can you see it now?
We can see your objectives, which are perfectly written. So thank you.
Right. Of course. So before I dive in, I'm
You
wondering,
hit the button again because it
hmm,
seems that there's an issue.
can you see that?
Yes, now it's fine. So you have to hit every slide twice for some reason.
Okay. So the question that I have is, what are some of the common barriers you face while teaching residents? If you work with residents, or if you don't work with residents, you could talk about fellows or medical students, but just in the clinical environment, I would love to hear any common barriers you might face.
Let me look at my
I'm gonna
audience.
stop sharing to see if I can fix whatever's happening with my weird share.
Okay. Anybody who works in clinical, if you could give some barrier. I know Dimitar's on, he's a surgeon in clinical. Dominic's a primary care doc. Donna works with nursing students. So anybody who has any thoughts on that.
Time is what I'm hearing a lot of in the chat. All
Oh,
right, multiple people saying time. Um, and I'm just gonna, I think Zoom updated for me right before this. And so I'm trying to figure out um, why it's not sharing like it normally does.
Rob brought up an interesting point I'll just mention, variable preparedness. And that's very true. We hear from clinicians, Rob, when they have a team of people, you have a student, you have an intern, you have a resident. How do you deal with the variety and the preparedness of people, whether it's from different levels or different contexts? So that is a real problem in the clinical setting as well. And since we don't have the gift of time to give most people, we have to figure out how to do it within the time that we have. none of us have the gift to give you more time. So I always say that. I don't know if Anna agrees with that statement.
Yes, I definitely do agree with that. All right. And can you see the slides now?
Yes, we can.
Okay. And what about now?
Yes, we can see
Okay.
your slides.
Okay, perfect. So, thank you all. I think that time sounds like a big one, and that is something that we also experienced. And so, one of the things that we found is that it can be really challenging to meet the demands of educating clinicians that are working in really busy, high volume clinical environments. And so, when we kind of were able to come around and realize that this was our problem, we turned to the literature to see what existed on adult learner preferences. And so what we found was that adult learners really prefer to have short, relevant, and applicable self-directed learning that is technology enhanced. And I think that that may be because of the Zoom era, but I think that even before Zoom and the pandemic, people were really moving towards technology enhanced learning anyways. And so technology enhanced learning, or e-learning, allows you to have trainees or learners be self-directed in their learning. It allows learning to be more flexible, because if it's enhanced by technology, you can move from synchronous to potentially asynchronous opportunities, and that allows more flexibility. It can be something that's continuous and ongoing, because you're not constrained by limitations in terms of when you can get large groups of people together to kind of be learning in a single space together. And most importantly, e-learning modules have been shown to be feasible and useful for trainees on busy inpatient clinical rotations. And there's multiple articles and papers in the literature kind of describing this well. So we kind of took all this together and decided that we wanted to utilize e-learning to help deliver some information to make it easier to teach learners. But how did we land on Chalk Talks? So
You need to hit your slides twice because it's
working.
still doing that.
Okay. Can you
Yeah,
see?
once you hit it twice, it's fine.
Okay. Do you see what our Chalk Talks now?
Yes, we
Okay,
do.
sorry about that. So let's make sure that we're all on the same page and talk about what are some of the key elements of Chalk Talks. So the first thing is that they're short. I've seen some excellent Chalk Talks that are as short as a few minutes, or could be even up to 15 or 20 minutes. And there is some literature to suggest that the ideal length for virtual Chalk Talks are right in the 6 to 10 minute timeframe. The second thing about Chalk Talks is that they focus on high yield clinical pearls. I think one of the beauties of Chalk Talks is that they can be used at the bedside or in clinic. And therefore, they're a really great way at talking through clinical pearls, because they can be inserted right into the moment where you're actually teaching. I often think about my training in the ICU, and I think about the fellows or the attendings having like a whiteboard marker and actually writing on the glass doors of the patient's room and kind of going through a short Chalk Talk right in the moment. Finally, when we were looking into Chalk Talks, we found that some of the best Chalk Talks incorporate an advanced organizer. And an advanced organizer is really a schema to help learners conceptualize a new topic. So this could include visual representations like graphs, timelines, Venn diagrams. It could be simplified cartoon drawings like a box heart, or even a simplified list. And then why do we use Chalk Talks? Well, the literature shows that they really check off a lot of adult learning preferences, and also they're highly rated. And so we're really hoping to capitalize on learners' motivation, which can be really helpful when we're thinking about their learning and retention. So what are TinyTalks?
Hit it twice.
Do you see it?
It's
I'm
coming.
hitting it sometimes.
I have no idea what's with your this.
Huh.
Now it's good.
Okay.
Perfect.
So TinyTalks, we kind of put together the literature we learned about adult learners and e-learning and Chalk Talks and created TinyTalks. So TinyTalks it's an online library of short Chalk Talk style videos of clinical pearls that are targeted to the level of the trainees. In this case, we're really focused on targeting pediatric residents, but you could also think about attendings that can be ongoing learners, fellows, nurses or nursing students, or other health professions education learners. And they're taught by interprofessional clinicians. And they're really designed to be used flexibly to meet the the needs of our learners, and we really want them to provide an overview of all pediatric topics. And so when we think about flexible use, that could be used for just-in-time learning. So someone could pull it up right in the moment of teaching or right in the clinical scenario when they need it. It could be used for self-study if they just are trying to prepare for a rotation ahead of time, or it could be used for flipped classroom teaching. We know in the medical field and in medical training, there's not a lot of time, as everyone mentioned, and also there's not a lot of prep work that seems to happen ahead of times. So you could also, you could assign a Tiny Talk to be watched ahead of a lecture or a time when you're coming together to do some group learning, or you could say, you know what, let's all get in the same room together and show a Tiny Talk and watch it all together. And it would be short. So every Tiny Talk has to be less than 7 minutes. And so if you have someone up at the chalkboard, that kind of didactic portion of the lecture could kind of expand and take a little bit longer. But if we just have a video we're watching, we know that it's contained to 7 minutes. We can watch it in 7 minutes, and then we can all discuss and kind of build upon that together in a flipped classroom session style.
And I just want to say, obviously, she said pediatric topics, but this could be used with any clinical topic. I just want to be clear.
Thank you. And so when we were coming up with Tiny Talks, we came up with, and we started, I should add on that and say, we started with pediatric content, and spoiler alert for the future, we have expanded outside of pediatric content. But when we were talking, this paper specifically was about the pediatric content. So I'll focus on that, but can certainly entertain questions or talk more about how this could apply in different settings. So when we were coming up with the design of Tiny Talks, we came up with 3 rules. The first rule is that all Tiny Talk videos must identify a category. So approach to, explanation of, or application of, to clarify the focus of the topic. And I think that topic selection can really be the cornerstone to a good Chalk Talk. And I think that Chalk Talks can really kind of balloon, right? The topic can really balloon if you don't specify what you're talking about. So for example, I recently was a mentor to a resident as teacher experience, and I went to go and watch the resident give her first morning report. And she said, today we're going to be talking about pain management. And I thought to myself, wow, this is going to be a really great refresher for me. I haven't thought about all the different types of pain meds and what receptors they go to. And so this is going to be a really good refresher for me. And turns out that's not what the talk was about. It was actually about all the biopsychosocial components that could contribute to a patient's pain. And it was a really amazing presentation about all of those factors. And it took me a few minutes just to kind of really get into the experience of what was happening and me being able to really engage with the material, because it wasn't exactly what I was expecting. If she had said ahead of time, this is going to be the approach to biopsychosocial risk factors that contribute to pain, I would have been on her wavelength from the beginning and would have been able to engage right from the get-go on what she was talking about. And so I think that's a great example of why it's important to have these categories that we came up with. So approach 2 is really when a teacher is going to explain kind of their thought process or how they think about a certain topic. So for example, if you're talking about reading EKGs, you may have an approach to, interpreting an EKG, and the teacher might go through, when I look at an EKG, first I look at rate, then I look at rhythm, then I look at this, then I look at that. The second is explanation of, and this is going to be more like an illness script, if that's something you're familiar with, where you're really kind of diving into some of the details or why something is the way it is. So if we were to stick with our cardiology example, you might say explanation of supraventricular tachycardia. And in that Tiny Talk, someone might go through, what SVT is, how you diagnose this, who's at the greatest risk, et cetera. And then the final category is application of. An application of is really bringing together some of the concepts that have been introduced in an approach to or explanation of video. So you might have, sticking with our cardiology example, you might say application of diagnosing SVT. And you could say, start with a little patient vignette and then kind of pull up an rhythm strip and kind of pull the approach from the approach to interpreting EKGs and pull from the explanation of SVT about how you might diagnose it, and then look at this and kind of interpret the rhythm strip together to come up with a diagnosis of SVT. So that is the first rule. I think one of the things that this rule also highlights is that cognitive load is something that's really important to consider when you're teaching others. And cognitive load could probably be a talk on its own, but really cognitive load at the root of it is that learners can only process a certain amount of information in a time period. And so by chunking information or bringing it into smaller bits of information, it's easier for learners to actually understand that and learn that content rather than have to do a lot of the work and try to make sense of a larger piece of content. And so that's what we're really trying to do with TinyTalks, is really chunk it down to focus the topic of each one. The second rule.
Does anybody have any questions on that first rule, just to be clear? Because that was a lot of information, so I don't want to get cognitive overload is what hit me. So
Thank you.
anybody have any questions? So the approach to, explanation of, and application of. Anybody? Okay, I think we're good.
All right. The second, and I get very excited about TinyTalks, so please feel free to jump in and stop me and ask questions as they come up. So the second rule is that all TinyTalk videos must be less than 7 minutes, with all material presented on one virtual chalkboard screen. And we talked a little bit about why we landed on less than 7 minutes. There's some literature that suggests 6 to 10 minutes is the best time frame for virtual teaching videos. And I think that 7 minutes also, it kind of plays into that cognitive load piece where it's a manageable amount of time. And we kind of did a little bit of talking with our learners. And when we were choosing between 6 and 10 minutes, 7 is kind of where we landed with their input as well. And then one virtual screen also, I think, helps with cognitive load because it's really minimizing the amount of information you're presenting, and everything has to fit on one screen. It's not like you're having multiple slides that you're going through. Everything has to kind of build upon itself in what we call the storyboard to kind of flush out this one screen that you could take a picture of at the end of the talk and take it away with you to kind of save and refer to later. And it's almost like its own notes of the talk itself. And so there are certainly things that people will say and they won't write on the storyboard, and that's okay. You really want to make sure that that one screen has really the highlights and the most important pieces of information. Questions about this rule?
Has anybody here ever given a 7-minute talk? Just to get a sense of that, somebody who has a feeling what it means, 7 minutes. For the app that I have, we're trying to make all the podcasts we're doing for the app, they're not really podcasts, but audio files, under 4 minutes. So it's definitely requires some concentration to achieve these numbers. I just want to point out it's not going to happen unless you're really monitoring yourself.
Absolutely. I think a lot of teachers think that they're going to be able to accomplish a lot more, and they quickly realize that they aren't going to be able to cover as much material as they had initially hoped. And there are a couple of times where someone will present to me an example, a rough draft of a TinyTalk, and I'll go through it and say, I think we have to split this into 2, or I think we have to split this into 3 sections, because really once you flush out all the information, what you've presented to me is going to be much longer than 7 minutes. The third rule is that all TinyTalk videos should use a 3-step approach that we came up with: the hook, the frame, and the delivery, which guides the creation of the video. And so we built the hook, the frame, and delivery concept. We made that up based on a lot of literature on how to make the best chalk talk. And so basically what we're saying is that the first thing you need to do is hook the learner and make sure that they understand why it's important. So the hook is an interesting opener that really grabs the learner's attention and helps anchor new information to come. And so this might present itself as a clinical vignette or an experience that you might have had in the clinical setting that might be relatable to other trainees or whoever your end learner is. For example, when I created the approach to teaching scripts, TinyTalk, I related teaching scripts, which is what we call the kind of outline of your Tiny Talk to recipes. Because if you haven't heard of a teaching script before, but you have heard of a recipe, you might be able to kind of anchor this new knowledge, teaching script, in the concept of what a recipe is and say, okay, when I'm building my teaching script, I'm putting together all the ingredients to make this final product. And that can make it a little bit more tangible for someone.
I just want to mention a little PR. We have a brand new JIT that's not on the app yet on what is a teaching script. So you're a perfect PR for me of that. I'm going to put it in the chat because it is not on the app yet. It's going up on the app in November, supported by video-based teaching scripts. So this could not be a better tie-in, Anna, because
Yeah,
we actually are connecting the teaching script concept to video teaching scripts.
that's great. I think that would be really helpful for people.
Right.
The frame is kind of the next piece of our teaching script. And we basically say that that needs to define the boundaries of the talk. And so you can do that by creating SMART objectives. And typically for 7 minutes, we recommend having between 1 and 3 learning objectives. We find that's the most that you're really specific learning objectives, that's really the most you're able to accomplish in a 7-minute video. The frame also is incorporating an advanced organizer, which we talked about earlier. And so that's making sure that the teacher is the one who's doing a lot of the work so that the learner doesn't have to make sense of jumbled information that's coming at them. It's already kind of presented to them in a way that they just have to kind of incorporate the knowledge into the information, the knowledge that base that they already have. And so that might be using tables or graphs or short lists or Venn diagrams or things like that, so that they can kind of have the information presented to them in a way that makes sense. The frame, we also say, means that you have to take into account who your target and learners are. And I'll come back to that one in a little bit because we have, because this is all in the virtual setting, it's hard to kind of target your learners, what learner level you're at. And so we had a way that we incorporated that into our TinyTalk process. And the delivery is really the main content of the talk. It's making sure that the actual information is presented in a short and concise way, and that the take home, all of the information relates to the learning objectives, and that you're able to come back with take home points that are related to, but different than the learning objectives that you have. I saw a couple things pop up in the chat. Let me see.
That was me.
Oh,
Don't
that was
worry. It was a teaching script, and then the mini chalk talk JIT also, which goes along with what you're talking about, but the teaching script also.
great. Any questions about the hook, frame, and delivery?
So far, just to say, I've seen 9 components that have to be part of this, if I calculated correctly.
So if you're talking, so if we kind of go backwards, so we want to make sure that you have picked a category. So it's one of, approach to, explanation of, or application of. So there's one there, but you get to pick from 3 of them. And then it has to be less than 7 minutes and all on one virtual chalkboard screen. And then it's kind of delivered by using the hook, the frame, and the delivery.
That's okay. Gotcha. So it's okay. Thank you.
Of course. And so I would argue that the part of the frame is that it's less than 7 minutes and that it's all on one virtual chalkboard screen, because that's kind of some of the construct in which you're creating it, the confine. All right, so now that I've kind of described a little bit about what TinyTalks are and the rules that we use to make TinyTalks, I'd love some initial impressions from the group. So do you think that this type of teaching might be helpful? Do you think they might meet your needs? Are TinyTalks something that you might use in your teaching?
So this is the open mic piece. If anybody could do that, and if you're in a place you can't talk, if you could chat with us, that would really be helpful.
And I would definitely make use of it because I find that our students today have a very short attention span. So this really, really would meet their needs. If it's short, it's sweet. They'll stay focused, they'll stay involved. So yeah, I'm looking forward to, I want to see how, like I need to see it to really conceptualize it.
Yeah. I was going to offer to show an example Tiny Talk at the end, but if it would be more helpful to talk about it now, show one now, I'm also happy to show part of one now.
Natalie, let me see what you were saying to us. Thinking for doing this, are you planning on becoming an up-to-date Tiny Talks? Do you know what she means by that, Anna?
We have our faculty who are doing this as a faculty development, so thank you very much, hence the group in the background. So that was Dr. Lipshitz's question.
Yeah, I mean, that would be
Natalie, could you say what department you are? I'm sorry. Could you just
Sorry, Division of Nephrology at the Medical University of South Carolina.
Oh, thank you for joining us from far away. I appreciate that.
I'm gonna send you an email at the end with all of the faculty who are here to be able to count for CME. They all registered. We're just watching it together.
Okay, that's great. Then we have it, no problem. But so what are you saying you're doing at South Carolina since you're out of our network, just to explain a little bit?
This is the Division of Nephrology. So we have fellows and residents and medical students who come through. So Dr. Lipschitz was asking, are you going to make it up to date? Is there going to be some kind of, I guess, peer-reviewed process to have lots of different topics in medicine that would be Tiny Talks that we could use as a reference? Got that correct?
Yeah.
Great question. So yes, that is the goal. So you're jumping ahead a little bit, but I can kind of tell you that to date, we have over 70 Tiny Talk videos between two different portals. So pediatrics is our largest portal. We have 50 some odd videos in pediatrics. And then we have a portal on content about how to be a better educator. That makes up the remaining Tiny Talks. When we first started Tiny Talks, we were worried about having it become too much of a burden to feel like people wanted to participate. And so when we first started, we did not have a peer review process because we thought that would just increase the activation energy needed for people to engage with Tiny Talks. But as of kind of early 2024, we're piloting a peer review process right now. So we're actively going back and peer reviewing all 70 videos Tiny Talks that we have created. We will incorporate any edits and feedback into those videos to update them to make sure that they are, accurate and correct, and kind of explaining everything appropriately. And then moving forward, we'll incorporate the peer review process before we actually record the video, so we won't have to go back and edit anything. So that's kind of the peer review piece, is we're working on creating that. And then the second piece of, we definitely want to create, make this be like a comprehensive library. Right now, we're really targeting pediatrics and how to be a better educator content. That's where I have funding from. And so that's kind of, I'm a pediatrician as well. So that's kind of where our clinical content is focused. But I could definitely imagine in the future a world in which we make more topics for other specialties as well. I think right now we're limited by kind of bandwidth. I have a small team of advisors, but I'm the only one that gets protected time to work on Tiny Talks. But definitely would love in the future to make it kind of available publicly. Right now we're behind a firewall, but I'm working with our team at Mass General to make it publicly available. There's a couple of hoops you have to jump through before that can happen. So we definitely would love to grow. I think it might take a little bit of time, but that's definitely an aspiration that we have.
Thank you. And also, just to brag about Natalie a little bit, she's doing a master's in medical teaching at Penn. She's our fellowship director and won the education prize for the whole university. So
I'm just gonna mute our division now.
Okay. That's great. And we do have some people on here who completed my master's, so I think it's great you're doing that, Natalie. Okay. You want to continue, Anna?
Sure. So now that I've kind of explained what Tiny Talks are, I would love to talk about how we developed and implemented Tiny Talks at Mass General for Children. This is outlined in the article itself. So the first thing we used is Kern's approach to curriculum development. And so I won't belabor this point, but there are 6 steps that you go through in Kern's approach to developing a curriculum. So you have to identify a problem. You have to kind of go to the literature to see what's existing there. You want to do a needs assessment. So we did do a needs assessment of our pediatric learners to understand what they were looking for, both in terms of how they might use this type of this resource, what topics they might be most interested in, who they might want to be the teachers. And that's where we landed on having interprofessional multidisciplinary teachers, because we wanted it to be residents. We both wanted, and residents wanted, to learn from people other than just MDs. And then we kind of talked through some of the methods we used to develop TinyTalks, and then some implementation and assessment, which I'll dive into in a little bit. And as we developed TinyTalks, we really focused on getting buy-in from our stakeholders. And so that was both the residents as well as the faculty. And so for residents, we did this needs assessment of them to understand what their needs were, which I just talked a little bit about. But then we also wanted to include them in the process of TinyTalks. And so we created a role called the resident TinyTalker, and they get trained in how to make a good TinyTalk. And then they actually participate in the process by attending dress rehearsal sessions with teachers before the TinyTalk is recorded, so that they can give feedback to the teacher about what they like and what they don't like about a particular topic. So I think I had mentioned earlier that part of the frame is making sure that you are targeting the appropriate learner level in your teaching. And in an in-person Chalk Talk, you can do that by asking questions and interacting with your learners and students, and kind of seeing where their gaps in knowledge are and what they know and what they don't know. In the virtual environment, you obviously can't do that as easily. And so we wanted to incorporate a way to make that possible. And so we came up with this dress rehearsal idea. And so after a teacher has created their TinyTalk, a rough draft of it, I pulled together one or two residents for this dress rehearsal. Typically it's done over Zoom, but it can be done in person. And we come together with the teacher, and the teacher goes through a dress rehearsal of their TinyTalk. And so they read through their script, they show their storyboard, and we use a modified rubric to give feedback about what works and what doesn't work. And the learners and teachers have really loved this experience and have really been amazing at both giving and receiving constructive feedback. Sometimes there's minimal feedback and the learners really like what's presented. Sometimes the learners will say, I really like the information you're presenting, but I think about it in a different way. Could you actually flip the order in which you present it? And that would make a lot more sense to me. A couple of times learners have said, hey, there's a lot of really good information here, and I think you could go into more detail about more of it. Could we split this into 2 TinyTalks, and we could maybe do, an approach to something plus an explanation of something. So for example, we have a couple of TinyTalks on hypernatremia, and we split it into 3 TinyTalks. One was the approach to diagnosing hypernatremia. One was an approach to how to manage hypernatremia, and then we had one that was application of managing hypernatremia.
So funny that you say this, because we have a JIT written by a nephrologist on how to guiding a learner to treat hyponatremia.
Oh, so funny.
So that's a complimentary, like a takeaway in the palm of their hand, which is great. So that's why I thought there was such a parallel process with our work when I found you or heard about you. So you're proving it by the examples. And I just want to say that most JITs are submitted with too much content also. And we have to say to people, this will make 2 JITs or 3 JITs, but this is not making 1. What can I take out of here? Exactly. Very, very common if you want it to be, infographic-like and really catchy. Go ahead.
Absolutely. So that was the way that we kind of involved the learners. We also wanted to make sure that we were able to get the teachers involved. And so as I was coming up with the process for TinyTalks, I went and basically did like a parade and tour of all of the division staff meetings to say, hey, this is what I want to make. This is what I'm thinking. Would you use this? What would you want changed? How could we get you to participate in making some of these TinyTalks? My pitch to a lot of the teachers was, you have spiels that you're giving and things that you're teaching all the time. Can we can that and put it in a TinyTalk so that all this great teaching you're doing, if you're not around, you could say to someone on nights or post-call, hey, I saw you admitted a patient with this. I know that you need to go home and you need to get some rest. Why don't you listen to my spiel about this on a that is created in a TinyTalk, and it prevents them from having to kind of, say everything over and over, or for the learner, it allows them to kind of get extra knowledge that they may have missed if they wouldn't have been there. We also talked to some of the faculty about This might help learners have kind of even the playing field, right? When interns come in, you don't know what their knowledge base is, particularly in pediatrics. And so by having some Tiny Talks on basic concepts, learners might be able to watch a Tiny Talk before they call a consult to say, hey, I know that this is what's going on. I saw your Tiny Talk, and so I'm thinking it might be X, Y, or Z. When thinking about this patient, could we talk about some of the nuance that we couldn't fit into the 7 minutes? And so it allows for some kind of like evening of the playing field, so everyone's on the same page, and then you can really build some more knowledge or nuance off of that. The second piece we focused on was coming up with topics. And so that was, we looked at the American Board of Pediatrics content outline for the board's exam, and we pulled some ideas from that. I think I mentioned we did a needs assessment of residents and understood some of the topics they wanted there. In the very beginning, we basically were just looking for early adopters and said to early adopters, you can teach whatever you want, just help us start building Tiny Talks up. And now what we're doing is we're actually kind of an adjacent project that I'm doing that was not outlined in the paper, but I think is something cool and interesting, is we're actually holding expert panel sessions in each of the divisions at Mass General to come up and build census on what are the most important curricular priorities for residents to learn when they rotate through that division. And we're doing that using the modified nominal group technique, which is a form of consensus building. And then we're using the prioritized list of curricular priorities that come from that to help us figure out what talks we need to make in Tiny Talks. And then the third piece was we wanted to come up with a kind of like what we call a process flow to make sure that, as Alice mentioned, there seems to be a lot of components going into making a Tiny Talk. So how can we make this pretty straightforward? And so I created this Tiny Talks timeline, which kind of outlines a step-by-step approach to creating your own Tiny Talk. So the first step is that teachers need to watch the Tiny Talk teacher training series, which got a little bit meta. And so it was the first Tiny Talks that we ever made. And it's a series of 5 videos, less than 30 minutes in total, about how to make a Tiny Talk. And so in Tiny Talk format, I walk teachers through an explanation of Tiny Talks, introducing them to what it is, an approach to topic selection, how do they pick their own topic, an approach to teaching scripts, how do they implement or utilize the hook, frame, and delivery, an approach to storyboarding, so how do they actually sit down with one piece of paper and draw out and incorporate everything they want into their Tiny Talk. And then finally, the approach to putting it all together and how do we incorporate all of those elements into a Tiny Talk and incorporate technology with it. So all the teachers will watch this 30-minute video and then touch base with me if they have any questions. They will then select their topic. And so there's lots of tips in the approach to topic selection Tiny Talk that they can utilize. So they have to select their approach to explanation of or application of, and then put in their topic that they would like to discuss. They run it by me to make sure that that's an appropriate topic that we don't have anyone working on already. After their topic is approved, they create their teaching script and storyboard using that hook, frame, and delivery approach and all of the tips outlined in the Tiny Talk teacher training series. And they will often check in with me virtually or via Zoom, or they'll email me and I'll give them some tips and feedback about how to, usually it's make things a little bit more succinct and get it closer to the 7-minute time frame. After they feel comfortable with their script and their storyboard, we set up that dress rehearsal session that I was talking about, where they get to practice the delivery and receive feedback from current residents. And then the peer review process that we mentioned will ultimately go, we're deciding whether we want it to be before or after the dress rehearsal. Moving forward, we haven't actually implemented that step yet. And then finally, they record. And so I meet with them at a predetermined location. I bring all the technology. All that the teacher has to do is record their voice. And then I have a college student now who is kind of our intern who does all the editing. And I actually am the one that writes out all of the storyboards because it provides consistency of handwriting to the learners. And it also can be time consuming depending on what is happening on the storyboard. And so I want to take the burden off of the teachers and I will draw out the storyboard for them. So that is the process flow that we have come up with. Questions on that?
You have a question. What kind of time are you talking about in your time to do all this? Is that something you're going to address or should I ask it?
So like how long did it take people? Is that the question?
No, you like
Oh, me.
as the leader of all this and, the editing, all the things you're talking about, your time.
So when I started this, I was a fellow. So I had protected time in my fellowship. It was a medical education and medical simulation fellowship. And so that's kind of developing all of this was part of my fellowship. And it was 2 years. It could be a 1-year fellowship. I extended to make it a 2-year fellowship to buy me more time. And then I actually have 40% FTE currently carved out to continue working on health professions education research, and TinyTalks fits into that. So I have protected time currently.
Right, but how long does it take you to make one?
Oh, I'll get to that.
Okay, great. Thank you.
So kind of getting to that point, the pilot TinyTalk curriculum results. So the pilot TinyTalk curriculum is what we kind of the videos we included when we wrote up this paper in academic medicine. So it was any TinyTalk that was created from June 2021 when I started my fellowship through January 2023. 28 TinyTalk videos were created during that time by 10 different teachers. Each video was produced by one teacher, one production editor, who was me, and then 1 to 3 resident TinyTalkers who were the learners at the dress rehearsal. So the average time it took for teachers was 207 minutes plus or 79 minutes. And that included the time it took them to watch the TinyTalk teacher training series, the time it took for them to come up with their topic, develop their script and storyboard, iterate their script and storyboard, participate in the dress rehearsal session, implement or integrate any feedback from the dress rehearsal, and then meet with me to participate in the recording of the session. I will say that I think I have not run the numbers, but we have continued to gather this data. And I think that that number has gotten a lot smaller, and that we do have data that shows amongst these this time, the first time TinyTalk takes longer, and then it takes significantly less time for subsequent TinyTalks. So if you make 4 TinyTalks, the first one, you kind of invest your energy in learning how to make it, and then subsequent ones are faster. The average time for me as the production editor was 188 minutes, plus or minus 53 minutes. I will also say that I had never edited a video before this, and so I was not very fast. And I think that now I'm much faster, and we have a college student who's our intern who does the bulk of the editing for us, which helps cut down on the time that I have to put into it. On average, teachers created 2.8 videos, plus or minus 1.32. And 100% of the TinyTalks that had a dress rehearsal were recorded and ultimately turned into an actual video. And then kind of, since that data is old, a little sneak preview of our current data. So as of October 12th, we had 3 portals. So the pediatrics portal, the educator portal, and the teacher portal. The teacher portal is the how to make your own videos, which you could argue might fit into the educator portal. We currently have 72 TinyTalk videos created by 27 different teachers. That leads us to my next question. So what do you think about the pilot TinyTalks curriculum, and how might you utilize TinyTalks in your own teaching? Or any questions about any of that data I just presented?
So, Rob, I'm just thinking about our revision of pre-work. This is like the ideal.
And so I see a question about, will these be searchable on PubMed? Not currently, because they are kind of behind a firewall currently. We do instruct teachers how they can put them on their CVs.
Which is the same as my app. The JITs are not in PubMed, but we do instruct people how to they get their name on it, that they created it, and then we instruct them how to put it on the CV. And CVs are accepting these things, at least I've heard that CVs are accepting these items. So I think that I think it is a source of I'm going to put publication in quotes.
Scholarship.
Scholarship. It is a form of what we call it, mini scholarship, actually.
Yeah, I think we'd certainly call it a form of digital scholarship. And to your question, Al, or to your point, Alice, about pre-work, I mean, that's something we struggle with at in the pre-clerkship years quite a lot, assigning pre-work. And it seems like no amount of reading or no length of video is short enough. So the shorter and more concise and more to the point, the better. I think that these Tiny Talks do a really great job of chunking the information, which is kind of a goal of these things, just getting everything into one kernel. And then it kind of seems like the sky's the limit in terms of how you could branch out and different topics you could do.
Absolutely. I feel like there could be an endless number of Tiny Talks. You can also add nuance, right? Like, so you could do a Tiny Talk on the routine vaccines in pediatrics, but then you could do another one on like exceptions to the rule, right? And then you could do another one on how to counsel families on vaccines hesitancy, or, it kind of is endless what you could do with them.
Right. It's interesting. The other thing that's relevant at pre-work is that eventually, if we had some students make these, because talking about relevance, what do they think is relevant and what we think is relevant is sometimes different. So student involvement in this is actually a great education project. And then using them, of course, in courses would give them feedback on how other students felt about it. So using the actual learner, or maybe a learner in second year makes it for first year and third year for one below.
We've talked a lot about having learners create Tiny Talks. We ultimately have landed on we want the experts to be the one to make Tiny Talks. And so we do allow fellows to create Tiny Talks, but they must have an attending supervisor. If it's not in the MD world, MDDO world, then we say someone practicing at the top of their license. So we've had some pharmacists make them, we've had some nurses make them, we have an SLP who's making one, and a learner, like a pharmacy resident, could make one, but we would want it to have someone fully practicing under their own pharmacy license to be their kind of oversight. We have not yet allowed residents to make them because for a variety of reasons I won't dive into, but that's a choice that we have made right now, but we can always reevaluate that as we kind of expand and grow.
I just want to say that I have a similar philosophy that all the JITs are made by content experts, but I have allowed residents who are residents in that content area to make JITs. But so like an OBGYN resident for OBGYN content. But I feel very strongly that all the content is made by a content expert as well. So that would contradict what I said about students. So I don't know why I said that when I contradict myself. Leanne, do you want to think about doing your slide and then we could see if there's any more comments or questions? Let me see if there was any. Can we access these outside of your institution?
Right now, no.
No, I got that sense.
Yeah, we're working with our lawyers and marketing team to make them more accessible. And so it's a work in progress. So not yet, I should say. Not yet.
Right. It is a decision to do open access versus not. That is a decision. It was a big decision for me with my app. And it's a little bit philosophy, it's a little bit finance, it's a lot of different things that go into that decision. And I do praise Northwork well for allowing me to have an open access tool. Leon, do you want one more slide? Could you go forward?
Yep.
I just want to have her do some bibliometrics on your article. So let's see what we got, and then we can go back.
Yeah, hi. So I'm Leanna Stager. I'm the Scholarly Publications Librarian for both the Sucker School of Medicine and the Northwell Health System. And I just want to talk a little bit about bibliometrics and the kind of attention this article is getting so far. All of these metrics are from the Dimensions database. So if you want to look it up there, you can. This article is fairly new. It's only a few months old, but it has already been cited once by an article about integrating simulation into the curriculum in the Journal of Cardiothoracic and Vascular Anesthesia. So it does sound like it's kind of escaping the PEDS world. And then looking at the Altmetric score, which tells us more about how this article is being shared on both media and social media outlets, we can see the article has been saved 6 times in the Mendeley Citation Manager, which indicates that the person is willing to go back and read it more carefully or read it again, and perhaps cite it in their own work later on. And it's also been shared 12 times on X, which is formerly Twitter, not only by users in the US, but also in the UK and South Africa.
Great.
Thank you. I didn't know all that, so that's helpful for me too.
Right. We try and incorporate this in our journal clubs because I think it's interesting to see how articles are being taken up. It also teaches people that when you publish something, you should think about how is it being picked up.
Absolutely.
So you can go back a little.
Yeah.
You have
So
to conclude because we have 5 minutes. Well,
5 minutes, 4 minutes. So kind of some of the discussion kind of topics that we said in our paper were that the TinyTalks paradigm outlines an effective educational strategy that accommodates the unique needs of learners and teachers. Given that they are short and accessible online, TinyTalks can be used flexibly for just-in-time learning, flipped classroom sessions, and/or self-study, and that this paradigm provides guidance and expectations to teachers to train them on creating effective educational sessions. In some of our next steps, we're continuing to scale TinyTalks by expanding our content library. We're evaluating the efficacy of TinyTalks through a couple of different metrics. So we track the number of views we get. We track kind of the statistics in terms of like how long it's taking us to make it. But we're also doing some interviews with both the teachers and learners, the residents, to better understand how the potential impact and perceived effectiveness of TinyTalks through semi-structured interviews. And so I'm working on finalizing the analysis of that qualitative data, and we'll be hopefully publishing that in the next little bit. And then kind of continuing to work on expanding TinyTalks outside of MGSC. And I know that we're short on time, so I will stop sharing my screen.
we had one more slide at the end, which is
Oh,
for
I
the
apologize.
evaluation. So I apologize. I do want to evaluate this. So we have to get the link.
Yes.
At the very, very end. I think I put it great. So this is for the evaluation, and you will get a copy of the PowerPoint, and we will send out the evaluation link. And if Leanne, I don't know if you can grab it and put it into the chat for us, that would be great. I can't do that right this minute, but you will get this link. And the other thing is that Elizabeth Schlegel, who's on, a colleague of mine, will be presenting about scholarly concentrations for medical students, looking at an international perspective. This is a big trend in medical education today, and medical student as teacher is one of those scholarly concentrations. And these mini talks like this is a great topic. Dominic, who's the co-leader of our track, certainly this is valuable to be discussing. He did a little bit of a chalk talk with our students already thinking about this. So I'm excited for next month, Tuesday, November 26th. So it's right before the Thanksgiving holiday. And we could take the screen down, and any last comments for this, anybody?
And I just
I
put
put
in
the link to the evaluation in the chat.
Thank you, Leanne, as always, for support.
And I also put our link tinytalks.mgh.harvard.edu. We do have, I think, 3 publicly available TinyTalks. So if you want to see an example, since we didn't get to share that this session, you can always go there as well.
Oh, that's great. Let me get that. Let me grab that.
And then if you have any questions, please feel free to reach out. I put my email in the chat there, and I'm going on vacation this week, so I might not answer quickly, but when I get back, I'm happy to answer any questions in the chat in my email.
Anybody have any last comments about this? If you weren't a believer before, you should be a believer now. What can I say? I think it's important to believe in young people like Anna, who's trying to make a difference in med ed. She's closer to our learners' age than probably many of us on this screen. So we should be listening to what she's saying as words of wisdom to all of us. And I want to thank everybody for coming. We're just at 1:00. So I think we're going to close out. And thank you, Anna, so much. And thank you, everybody. And we'll be sending everything out.
Thank you for having me.
Bye-bye.